All right, I'd now like to continue this discussion about some of the challenges and opportunities facing clinicians with welcoming to the stage Dr. Farzad Mostashari, who's visiting fellow here at the Engelberg Center, and also Dr. Mark Wagar from Heritage Medical Systems. To keep things moving, I'm going to ask you to take a look at the bios that are in the packets you received to get more information on the very distinguished careers. You all can come on up, and we'll get the microphones attached to you while I finish these introductory comments. Anyway, the bios for these and our other speakers today are in detail in the packets that you all have received. We're going to hear a little bit from Dr. Mostashari and Dr. Wagar about some of the issues that we've already raised this morning, particularly some of the opportunities and the challenges facing clinicians in these efforts to align payment reform and healthcare delivery reform. As you heard from Dr. Burgess, this is different. It's not going to be easy for many clinicians, but it also opens up some new opportunities for clinician leadership. So I'd like to, Farzad, turn this over to you to talk through some of those opportunities and challenges facing clinicians, and particularly those in small practices, maybe like the one in Muleshoe that we just heard about.
Thank you. There was a recent article, a well-done survey of physicians in terms of their attitudes towards payment reform. And I was struck, Mark, that they believed largely, they were enthusiastic about reducing healthcare costs through improved care coordination, through better prevention, through better management of the chronically ill patient. But there was a cognitive dissonance because when asked whose responsibility is it to reduce healthcare costs, they said it's the hospital's responsibility, it's the health plan's responsibility, it's the government's responsibility, it's everyone's responsibility except for the physicians. And when asked if they were supportive of or enthusiastic about the elimination of fee-for-service, 7% of physicians, echoing, I think, the sentiment that Dr. Burgess provided, said that they were enthusiastic about the elimination of fee-for-service. So we have here the situation where this is physician payment, after all, that we're talking about, where they believe that the way we're going to reduce healthcare costs, we should reduce healthcare costs, is through better management of patients, and yet those very same individuals who hold the keys to better management of patients say, not me, don't look at me. Tell me a little bit about, actually in the audience, Mark, about your perspective and in thinking about helping independent practices get past that perspective.
Sure, I think it's an appropriately pregnant conversation. It's something we have to go through, and I think that the discussion today is probably the first time in my 40 years in healthcare where we're at one of those points where we might actually take actions that the congressman talked about and others to change the way we do things across the board. We've got lots of pilots and examples of particular markets or particular physician groups or entities that make changes, but we haven't talked about changing the way things are done, in terms of how the financial system drives the way we take care of patients, and I think that's the key. Just a little background, Heritage Provider Network has 1 million patients in California, New York, and Arizona. 800,000 are entirely prepaid, full capitation. Our physicians are in about 50 medical groups that are clumped in regions and sort of behave as single groups. But we also wrap around those, and in some markets only have independent practice associations. So these small practices that you're talking about, we've actually taken the advantage of being paid entirely differently for most of our patients and surrounded those small independent practices with a different approach. We have the luxury when you're paid that way from the top down, and the physicians essentially are controlling the resources to pay the physicians differently. We don't have to wait in that instance for a change in a bill or what have you. Some are capitated on a prepaid basis, some are paid salary, some are paid fee for service with incentives. But all of the incentives, or the way that you're most successful personally in your practice, is whether you hit all the quality indicators and whether you're an efficient utilizer of resources. So I think the fear that you see is because people aren't familiar with how much that sets the physician free. And I think it is a fallacy that is promulgated by people who would like to own all the physicians, that you can't possibly do any of this unless you're bought up by somebody.
So let me ask you about that. We're talking about physician payment, and if the physician's employed by a hospital, then you don't have to worry about that. And a lot of people say, why are you worrying about the independent practices? They're going the way of the dodo. The hospitals are buying them all out. What would you say to that?
I would say that probably goes the same way of the 1980s, when we all thought there were going to be 3 or 4 super meds and hospitals were going to own all the insurance business and all of the physicians. We've been down that road before. And from a policy standpoint, if you really want to create patient-oriented, responsive, consumer, effective, and efficient systems, you want several approaches. I think there will be hospital-employed physician systems that work well. And we've been down this path before. There will be some that don't. If they continue to acquire physicians and talk about integration and change, but all that really happens is they want to turn a $1,000 MRI at an outpatient center into a $5,000 MRI at the hospital. It's a zero-sum game. We're not helping the public. We're not helping the practice. We're not helping the insurance premiums that you're all concerned about. And ultimately, it is the physician's responsibility. It's the physician's assessment. It's the physician's pen that writes the orders. It's the physician's compassionate conversation when it's done right at end of life about what the options are and what the most effective, best use of your remaining time is, and how to use this magnificent delivery system we have when it's done right. And I think, same with big multi-specialty medical groups. You have, is everybody going to belong to one? No. Is it possible for independent physicians to behave well in terms of overall effectiveness and have that machinery? We do that at Heritage. Our independent practice in New York, for example, the Wild West of the East, in terms of everybody wanting to not do anything different because I didn't think of it, is typically the initial response you get. We have 12 or 1,400 primary care physicians that have 100 fewer admissions per 1,000 on their Medicare population than the general New York marketplace. 100. If you applied that across the country and on the entire Medicare block of business, I'm not an expert at how these calculations are made for the government accounting office or whatever, but I guarantee you the numbers would change. And that's the kind of thing that you have to fuel. Heritage is not the only organization that does that. There are others. The other theme
Sorry, Mark, let me add a piece of data.
Sure.
I guess, unlike what Representative Burgess said about members of Congress, here, I guess we can do some data about the proportion of physicians who are currently work for hospitals. AMA recently did a survey. That's 15%. And those that are in hospital-affiliated practices, hospital-associated arrangements, that's another 24%. But 60% of physicians currently work in physician-owned practices. And 25% are in practices that are in small, independent practices still. And that has shifted since 2007 by 8 percentage points. Mm-hmm. So we're a long way away from hospitals owning all physicians. And as you point out, I think you were actually involved in some acquisition of physician practices in a previous life. That doesn't always work out so well in terms of physician productivity, and we've seen that pendulum swing and swing back again. So I totally agree with you that if we're talking about alternative payment models, we have to think about physician practices and independent physician practices being able to participate in those. The concern, I guess, a lot of people have is it's great to be encouraging them to move into this new kind of model, but can they do it? What are the risks to them? We've also heard, right, from physicians saying, we went on down capitation and we lost our shirts. We know we're never going to do that again, right? So why is this time going to be different, Mark, in terms of physicians entering into risk contracts?
I think the previous time around, some, but not all physicians who entered into those kinds of arrangements weren't experienced, didn't have the data. We have different kinds of data today. I think you have more sophisticated payers who will participate in that arrangement with better data, better expectations, sharing risk, if you will. So I think there is opportunity there to stop loss your risk or other things. But until you get more physicians participating in the idea that there is a budget, I mean, from the top down, from the federal government down, people are saying there is a budget. If you're in a union, if you're in an employer, there is a limit to how much I can pay. And if there's some truth to the fact that somewhere between 20 and 50% of what we do is ineffective, and if we're able to be more proactive, it wouldn't be necessary at all, we could get rid of it. Why would you not want to do that? I think the only people that can drive that are physicians. A lot of people use...
Can they profit from that?
Absolutely. And I think that's what you have to gradually replace components, not necessarily all, but components of the fee-for-service system with, which is right now, if I'm in a small fee-for-service practice, it's driven by I either wait or create events to bill for in order to manage my small practice. And that's not,
Wait or create.
Wait or create, and that's not a negative statement. 99% of the physicians out there want to do the right thing, but if you want there to be somebody at the front desk, you want there to be a nurse to help them, and you want them to be able to have a phone system that works, et cetera, they have to get paid. So in a fee-for-service system, it's reactive. As you change the payment model and you move to bonuses, which are sort of managed care light, you start to prepay some of it up front, which is particularly important for primary care physicians. So it's nice to be able to pay a primary care physician for a consultative or care planning visit, but that's still generating an event. It would be much better if they're in systems like a Heritage or like others that wrap things around the independent practices where we can pay you upfront ahead of time monthly for the care management and anything else proactive you need to do, plus a fee-for-service component, because if you're really good at taking care of the brittle diabetics, you're going to get more of them. So you may need some fee-for-service component.
Mark, I heard you say under your breath, 10% increase for primary care isn't enough. That's not going to do it. Just paying more for fee-for-service by 10%.
Right. I see the use of the penalty money in the SGR fix being pooled for incentives. I think that's a great move, because anytime you just cut payments or what have you, you're going to force that wait or create practice to create more events. And they may never catch up, as the congressman said. They may not make up for what they're getting paid less, but you're just going to get more activity that's useless. So I think that for primary care, if you just sort of back into, well, we won't make any decisions about which specialty should get more, so we'll just make everybody have a 10% opportunity. If you're a primary care physician in any of our urban markets struggling to make $150,000 and unwilling to recommend that your children go into primary care, is 10% enough? It's a help. It's better than zero. But unless you get those physicians in a position as a specialty to say, I could make $300,000 to $400,000 a year because I'm saving millions by actually being able to be proactive, by finding out, why Mark Wagar didn't get all the tests ahead of time and an information system feeding me that and bugging the devil out of me.
It seems unseemly for primary care providers to be paid close to what proceduralists are paid. That's an interesting perspective.
Well,
there.
I think there's an opportunity for enlightened proceduralists, if you will, if I can use that term.
Mark, what do we need other than financial incentives?
I think information systems. So If you don't know ahead of time which ones of your patients are getting into trouble, whether it's by indications of they're seeing multiple people, their medications, whether it's they haven't you haven't seen them in 18 months.
If you can't count, you can't be accountable.
In a fee-for-service practice, you're just taking care of the people you see up front. In a practice that has heavy incentives, whether part of that is a bonus or a fee, or whether part of that is a prepayment component, you're most worried about the people you haven't seen in 18 months. What happened to Mark Wagar's mother? Why hasn't she come back in? She had a problem. That's a ticking time bomb from a payer standpoint, whether the government's going to pay for it, whether United or Blue Cross is going to pay for it. We all pay for it in the end. And if Mark Wagar's mother's next admission could be avoided entirely, delayed, reduced in its severity in terms of what she goes in for, because we're reaching out to her, getting her in. If you don't have that information, you don't know. You might say, I'm really busy. I'm an effective primary care physician. I've got 2,500 patients, but you don't know anything about 2,000 of them? You only know the 500 that are coming in all the time because they're so sick, because they're not being proactively managed. The other 2,000 out there are just ticking time bombs. So you have to change the way that things are taken care of.
So they're going to need data systems, and well, that's something I spent a few years trying to help happen. And nationally, the adoption of electronic health records has actually been faster than the adoption of the internet, so that's pretty good. And those systems are increasingly in place. What else do they need in order to be able to successfully make this transition?
I think you have to have an infrastructure where you can talk to each other. So one of the advantages of a big multi-specialty group that's physician-driven is you've got a lot of clinical interaction. If you're out there in that small community, I forget what's the name. What was the name of it? Muleshoe. So our equivalent might be Boron, California. So we have the High Desert Medical Group, surrounded by independent practices as well in the high desert around Lancaster, California. And if you have ever driven there, it's a path for Los Angeles people from there to Las Vegas or what have you. But lots of military, lots of small communities. In that community, we have leadership. And that's another key that you have to develop, that you have to nurture. This is like a business. So most of the big high reputation medical groups or practices, whether they're primary care or specialty or big multi-specialty, have a matriarch or patriarch leader who is a visionary, a founder, but had the combination of clinical business skill and personality to drive change. They're where you want to go because they made changes. They didn't sit still and just do what everybody else does. How you replace them when they become emeritus and are no longer involved, and then all the youngsters, sort of like your family, fight over the inheritance. That's key. You have to build physician leadership, because if you look around the systems, everybody wants to go to a conference where Geisinger or Sierra or Kaiser speaks. Okay? They aren't in 50 states.
Right.
They aren't in every community. They haven't been successful every single place they've tried to expand because healthcare is local. But what's the reason that Heritage is successful? The core reason. What's the reason that Kaiser's successful? What's the reason that Geisler's successful? The physicians take charge of what's being done, whether it's right, whether it's effective, and how much it costs. Those systems that own their own health plans and own their own hospitals did that because it was a mechanism for the group to, in fact, change the way they were able to take care of people. There was the resources. Heritage does that not by owning hospitals, but by partnering with hospitals. But it's the common thread is that these are physician organizations driving the change. You won't get the combination of quality and cost change that's sustainable unless they're in a position to drive it.
Mark, so we talked about data, we talked about leadership. Let's talk a little bit about supports. We met in New York City when you were with Empire Blue Cross Blue Shield, and I was helping 232 small independent practices adopt electronic health records and really start to be able to look at those who didn't walk in the door, right? And one of the things that we, I think, shared was the belief that small practices can have the same sort of ability to manage populations as those large integrated delivery networks, but they needed help. And they didn't go to medical school to be project managers for an IT project, and they've been practicing a sort of fee-for-service medicine for many, many years. And to make that shift to understanding the denominator, to being able to use the tools effectively, to implement nurse-driven protocols, to do team-based care in a different way, to do patient engagement in a different way. You don't just need the tools, you need to actually have someone who can go into the practice and help them re-engineer their processes. Tell us first what Heritage Provider Network does to help that independent practice that gets onboarded onto the network. And then tell me, who do you think is going to do this for all those independent practices who do decide to make the jump into one of these alternative payment models?
Sure. The kinds of things we do are essentially, and again, driven by the fact that we're paid differently. So we have this bolus of cash up front. So we can decide up front to say, well, if we believe we can sustain this 100 admissions fewer per thousand, that just doesn't happen out of the air. That means we're collecting data. That means we have people interacting with the independent offices as well as our groups.
And would you say that having an upfront fee and advance payment of sorts is going to be a necessary component to help people make that
You have
transition?
to evolve to that. What I see in the fix is I would say the sense of urgency now in the Congress overall is to be rewarded. I mean, we're applauding for very few things these days, but if they actually pull off, moving toward a replacement, that's bipartisan movement that we need. But I think that the kinds of things that have to happen is the moving towards at least some partial prepayment is essential. I'll give you an example that's not in one of our groups, and I saw this at some other conference. And this was a patient up in the Pacific Northwest, either in Portland or Seattle. It was an elderly woman in her 80s, lived on the 4th floor, had no elevator. But she walked around, goes up and down these stairs every day. But every summer, she had congestive heart failure, all the things you kind of get into. Every summer, she had a $100,000 emergency event. And people looked at this and said, well, what's wrong? What's the delivery system doing wrong? Whatever. You know what they finally discovered? That there's a month a year in the Northwest when they hit their peak temperatures. That was the year when she walked up those 4 flights of stairs coming from the grocery store or what have you, that her body couldn't recover from the heat gain and the stress of doing that in the 90+ degree temperature in a humid environment. And she had that event. What was the solution? Cardiologist, pulmonary consult, what have you.
Air conditioner?
A $200 air conditioner in her window. That stopped the events because when she got to the top of the stairs, she was in a cool environment, was able to recover more quickly, what have you. In a Heritage, when we're prepaid, that decision to buy a $200 air conditioner is made in about 30 seconds. And we have teams of people who do that. In a fee-for-service system, well, who's going to pay for it? Does Medicare pay for air conditioners? Is there a billing code for that? But if you're prepaid and you're looking at the total health status of the patient and what her cost is over the next decade, and you're responsible for making those decisions, but you have the freedom to use some of the dollars in the system differently. You don't have to wait for an approval or what have you. You can make proactive decisions. And that's a simple example of something. There are thousands, there are millions of examples like that. And you typically have heard about it before. Well, somebody can't get in and out of their house. Build a ramp. $650 for a couple of community carpenters to build a ramp for somebody to get in and out of their house. There is no billing code for that. If you're prepaid and that's going to keep your patient healthy and active instead of in a facility or what have you, you build the ramp.
My father-in-law was one of the, Harris Berman was one of the first to do the HMO in New Hampshire, and he talked about how they hired orthopedists for the first time, and the orthopedist said, these patients need handrails in their houses. Mm-hmm. They always knew,
Right.
But finally they had, if they were prepaid,
Yeah.
they had the incentives to
Yeah,
do it.
the whole idea that the system will collapse if you move away from traditional fee-for-service is complete bunk, complete bunk. It doesn't have to go away, and there are circumstances where it shouldn't go away. But unless you put physicians in a financial position to drive the decisions more on behalf of their patients, you won't get the proactive change that improves health status and moderates health trend over time. These are the kinds of things that could change the Medicare trend factor by 2 points.
CBO hasn't scored it yet.
Crank that through the numbers. I'll be happy to go sit with them. I guarantee you it improves things. And let's not be afraid of it. Will there be some winners or losers? Yes. My own opinion about the SGRs, be more aggressive. Go all in. Put all the money on the incentives, whether they're bonuses, fee for service, some capitation. Leave the people who don't want to do anything at zero. I wouldn't do a cut because it's just going to generate more volume, but leave those people at zero. You will watch people figure out a way to organize. They will find organizations that can help them with the data, whether it's a Heritage or somebody else. They will create their own. But this can't be where we leave some of the heaviest lifting until 2023. I realize we have 10-year horizons we have to plan for, but those of us who actually try to help physicians manage this, you have to create this change in the next 3 to 5 years, or the disaster that's going to occur in the time period after that is unimaginable. But we can make this change.
The framework, the SGR framework from Senate Finance and Ways and Means also said that there should be some federal funding for supports for rural practices, small practices, underserved communities that the market wouldn't traditionally serve. They also put a placeholder in there of $15 million for that. Now, we did the Regional Extension Center program, you may remember, that helped 140,000 primary care providers in those small and rural practices. And it cost us about $5,000 per practice of subsidies to get them that support. Do you think that's the ballpark of what would be needed in terms of boots on the ground support? Because if it is,
the 15 million?
Well, 5,000 per provider. If it's about the same ballpark, that means you're only helping 3,000 providers.
Right.
Is that enough in terms of a federal support for it, or do you think the market will take care of this?
I think if you were going to stimulate it federally, I think a bigger total number is required. You need to reach more of the physicians. But a one-time bolus of support isn't enough. I mean, what we did in New York City together, just so you're familiar, we went in, the city did, when Farzad was there, he pushed, the city went into small practices, 2-person practices in the Bronx, in the basement of an old brownstone and things. I went to visit some of these. And, they put up most of the money. We added some to put electronic records that were predictive, that were suggestive in the practices and gave them the handheld capability. But then what we did as Blue Cross is I went back to my office and got the network people, and I said, find a way to pay these doctors that sign up for this more. Mm-hmm. Because the one-time cost is just to get the thing in place. For a small practice, you have the disruption of installing it, and then how do you maintain it on an ongoing basis? And I just made a decision, a fundamental decision, that these physicians are doing something that we believe in. We're investing in the equipment and the system, so why wouldn't we pay them more if this is going to pay off? And the payoff was when they adopted these systems, you could see the patient compliance rocket up. I mean, literally within a 3 or 4 month period in terms of the right test, their blood level results improving or what have you. And then for this one system that was used, I think there was a 2-month period where they had to do system maintenance. patient compliance dove. The moment it was back up, it went back up. Not because these were bad physicians. This was because when the system was working, it was giving them instant information that Mark Wagar didn't go for the test you told him to get. You've got to get the big jerk to get his blood done, before he, his liver fails or what have you. And it worked. And you can do that, but I think there should be incentives, but payers should line up with the federal government when they make this change and say, for the people who are going this direction, whether you're in an ACO, a medical home, whether your specialty practice adopts all of the best practices, what have you, you're the ones who get more money in a form that you can take better care earlier of these patients. And the rest of the people, if they never change, so be it. I think the doctor in Muleshoe, you don't have to you don't want to cut his fees, but if you told him tomorrow you're going to get $10 PM or whatever the number is, plus your fee for service for your complex patients and what have you, he'd probably light up and say, you know what, I can do all kinds of things for my, Texas, remote location where it's 105 in the summer. I can put an air conditioner or arrange for an air conditioner in that person's office too, even in a one-person practice.
You bring up the role of the payers, and we do see a lot of the payers moving into ACO enablement, right? They want to help the independent practices stay independent, and I think in some cases not get into the scenario of the hospitals that totally dominates that local market. But one of the ways that they're doing it seems to be to offer to give them, the practice, the tools, or a care manager, or a case manager, or some services, right? Mm-hmm. As opposed to what you're proposing, which is just pay them more money, help them. If there's a brave group that says we're going to be accountable care for Medicare, which is 5-10% of their patients, fill it in so that they can do that for 50%.
Part of it's pay them more, but these independent practices will need support surrounding them. And so
is the
have
payer the right group to provide that support?
I think the payer is the right group to provide that support for the portion of physicians who can't figure out how to attach themselves to something, to an IPA, a heritage-type organization, some other organization that can provide the data and what have you. And as a payer, I always looked at it that way because I've spent half of my life on the provider side and half on the payer side. When I was on the payer side, I said, the best place for the decisions to be made is at the point of service. So while this is not a production line, it's just like GE pushing for zero defect. The most effective production of that airline engine we all depend on is when the people actually putting the parts in place and what have you have the best possible information. They're free to make the best possible decision at that point in time. If this bolt is not going in correctly, even though it costs $2,000 because it's a specialty bolt, I can take it out and I can put in another one. I don't just have to go along and not be thinking ahead about the accountability for what's going to happen. You have to put physicians in that participation. They are going to have to be attached to something, but I don't, that is an attraction. So for the employed hospital systems that do that well, that's a good place, and that'll be a good place to take care of people if it's integrating to that sort of that, high quality and zero-sum game, actually moderate the cost, not just protect your bond rating and buildings that are now going to be empty. I think multi-specialty groups do that, and then there are organizations, the better IPAs, the better organizations, what we do with independent practices. In the markets where we have groups, we said, we aren't going to own every physician, and you can't own physicians. I hate that word. You don't own physicians. They have licenses. They can go practice with their brother-in-law 3 counties away, wait till their non-compete goes away, and come back and take your patients. So, don't think that you own them. But you can enable them to do very extraordinary things. They're pre-selected for their intellect, their intelligence, their scientists, they're competitive. Give them information and allow them the financial capability to be successful in a different model, they will go there.
Thank you so much. This has been a great conversation, Mark.
Okay, good.